All right, so welcome to the first section on AI for social good. Our first speaker is Dr. Helen Chen. Dr. Chen is a research professor who holds a joint appointment in the School of Public Health and Health Systems and also in the Cheriton School of Computer Science. Dr. Chen is also an associate director of the Professional Practice Center in Health Systems, and she's the faculty lead of the WHISTL research group, where WHISTL stands for Waterloo Health Information Systems and Technology Lab. And today she's going to talk about her work on that at the intersection of AI, natural language processing, and COVID, with the title of her presentation is Optimizing Pre-trained Clinical Embeddings for Automatic COVID-related ICD Coding. Professor Chen.
Thank you. Thank you, Peter. So let me share my screen. Okay. So I gave some thoughts, and with the title announced, can you hear?
Yes, we hear you fine.
Yeah. Can you hear my screen?
Yes, your screen.
Okay. Yeah, so I changed the title to AI for Healthcare. And looking at what a range of things we do to be useful for the clinicians and together by the clinicians. Okay. And so my title, but today my talk would be, what can AI do for healthcare? The AI can help with organize tons of data in healthcare, and they can extract and finding meanings and faster probably than human chart review. And also they can reveal insights for achieving the optimal care. Okay, so I'm going to follow this trend of thoughts and to introduce some of the work we've done and together with our clinical partners. Okay, so when you look at the health care and from AI point of view, we look at data, right? So there is a lot of data and no industry generates as much data in different formats and from most diverse sources, probably than healthcare. Yet, probably no industry is like in healthcare that we know so little about what to do with that data. Okay, so I believe that, yeah, so there is a slight delay of the slides when I talk. I don't know. I apologize for this delay. Okay, so if you look at what data is helping in industry, in any industry, in healthcare particularly, to help them making the decisions. So there is, we call the maturity level of data-driven decision making. There is from the traditional analytics that everybody knows we want to have a few SQL queries and write some reports and understand what happens, how many patients pass through my hospital at the emergency room, etc. So all the way, if you look at the stages of that data is used to make the decision, to help making the decision. As an ad hoc, so from the standard report, we call the pre-canned report, the predefined certain reports that the data, healthcare data can provide regularly for the clinicians, for the management, for the ministry, etc. So that is a bulk of the work. Lots of people involved in extracting the data, generating the report, sometimes manually with Excel sheets, with a pen and paper, sometimes with more advanced technology as a database technology, and well, later to show how AI can actually help even at the standard reporting stage. So all the way you look at that, the data and understanding the data, modeling of that code, all the way to the last stage, highest, is that we want to say optimize the clinical treatment pathway and find the best outcome and personalized. Because the best outcome for me as a patient may not be the best outcome for you, yet another patient. Some cancer patient wants to have the least side effect, maintain a certain mobility and life quality. Some patients actually desire to live much longer. So there's always a trade-off of those kind of a treatment, right? And you take this medication versus you go on that course of treatment. So that is the highest kind of, we can see AI may be helping us one day, and we haven't achieved that yet, but that's ultimately is a prescribed AI and actually translate into optimal personalized care in the healthcare. Okay. If we look at the challenging of organized data, the data in healthcare, it's unlike the data in the other industry. We always said that finding some excuse why this particular segment progressing so slow in terms of computing, in terms of using the benefit from the latest computing technology, is that we have the data when they captured from the multiple points, from multiple people in their multiple mindset. So when they write down the notes, when they capture a value, there is a different meaning, using probably same word but mean differently, or actually the same meaning, but they use all kinds of different words to express that. And sometimes it's implicit, logic is implicit, it's not always very explicit. And also depending on the clinical environment and usage of that data or recapture and the recording, right? So, and of course, in the healthcare data, it's unstructured, multimodal, you have free text, you have some lab values and highly structured, and you have images, you have genomic sequencing, etc. So it's a very wide range of format. And actually, to make the matter worse is that data generating from one source, and even the same data, they may actually not really be able to interoperable talking to each other. They actually need a harmonization even to make them the same data when you look at such as a cancer recurrence, how you define that cancer recurrence or first actually disease progression free timing. So all those definitions, maybe the two data sets are actually defined differently. Okay. So let's look at, again, the traditional analytics. Often we need to write a report, we need to have some standard report, ad hoc report, and we need to do some query drill downs, and every hospital probably have some dashboards, and looking at the stats and looking at how the hospital is doing for the operational clinical point of view. So how we can help it is that actually extracting those data to be able to generate those reports. It's not as simple as I run a query from your database, from your warehouse. So that data, the very rich data, is actually embedded in the elaborate clinical reports and the clinical notes. But they often are text documents that are created by different physicians for each patient he encounters, and lots of notes actually was generated even by each encounter. But they actually needs to be codified, need to be standardized, codified into reporting for the data analysis. Typically, we pick up example that typically we use in this country, in Canada, we use ICD 10CA version to report what you've done, and what patient you treat, how long it take, what kind of symptoms they have, and what is the progression of your treatment, and etc. Right? So that is actually a daunting task. And every hospital, every clinic has a person hired full-time and coding those on a regular basis. But also when you want to do research and you want to extract the data, chart review, and take a long time. Okay, so what we get engaged is that let's actually look at if the AI can help with identify the appropriate coding, just like the coders, right? So then they see if they reading enough document, reading enough the notes, whether they be able to predict what kind of codes you should consider to code it. So that is what we have. But the challenge is that they have lots of codes. It's not like the binary, you are positive and positive, negative. They actually can have hundreds and thousands of codes from a given hospital. Even for a specialized department, easily you can have 50 plus kind of codes regularly will be used. So, and also they have ambiguity in labeling, right? So then the certain things you can label them in the 0.12, and sometimes also have the hierarchical labels you continuously discover. And it depends on sometimes reporting purposes. They also have the differences. They label them, give them the categorizing differently. And the nested logic and codification, extremely imbalanced data sets. Some label, some diagnosis or procedures treatment, it's kind of common, especially if you specialize in a certain disease area like the cancer programs. But if you are in the emergency, in ICU, etc., and in a general hospital, and they actually can be extremely imbalanced data. Sometimes as one in the 15,000 notes you read, probably that kind of a code appeared once. So anybody actually in the machine learning community know that dealing with extremely imbalanced data sets is always very challenging, and the codes always changing, evolving, etc. So recently, what we're doing, my original title would have been actually training the deep learning model to identify the ICD code, particularly the COVID-19 codes, because since COVID-19, and there's a bunch of new codes being added to the ICD coding as well. We have to have a faster reporting to the country, and actually in order to monitoring the disease and allocate resources, etc. So we are developing a deep learning contextual model pipeline to predict the medical codes from the clinical text. And we use contextual models for the sentence classification, and then we use a pre-trained long-former model on the mimic data sets. So the problem of traditionally what we have now, so like if we say that the deep learning in NLP, probably most advancement right now is actually using the BERT model. And then you look at they actually have a limitation. They take the 500 tokens and the maximum of 500 words, but the clinical reports and page after page, definitely 500 words is not going to capture the fullness of the context. So the long former model is be able to take up to 4,000 tokens that is particularly suitable, hold some promise, I would say, that they will be able to process the notes, clinical notes, much better than the traditional NLP model. Okay, so we look at the pre-trained models. This is probably as far as I go to the technical part, is that we experiment looking at all right now the state of the art NLP architectures and model. They pre-trained as a BERT model, and they trained in reading the Wikipedia, reading the literatures, and understand how the language and their relationships. And now also we take this pre-trained brain, so to speak, and to read the clinical notes. So the mimic notes here is actually a very large corpus of electronic patient record generated in a US hospital and in the ICU setting. Okay, so then they published that it's openly accessible electronic patient records data, and lots of AI model is trained using this clinical model, using this data source. So that's what we are using as a data source as well. And then we layer them with a classifier and predict that, see if giving a sequence of notes, and what the top 5 or top 10 or most likely ICD codes you're going to derive from this set of text. So that's what we are doing right now. So with the training is still ongoing extremely. If you also use a long former, that the computation extremely expensive. So that's where the Microsoft support and the Google's the cloud computing support extremely helpful. In this case, that you train them many cycles, many days, and eventually you train that model. They understand those connections, dealing with the medical terms, dealing with the medical context. And so far, we actually beat the other traditional models. And but you will see that, well, so we are doing the benchmarking. We want to have the best coding machine so far in this field, right? So you can see that this actually we are quite happy to see the results, at least with a benchmarking point of view. We are doing well. Okay, so that is one way of doing this. So in a way that the impact, let's go back to the impact of looking at these numbers. The impact is that even I cannot completely replace the coders and the chart reviewers and etc. But if I can reduce their load by 90%. And also, I will prompt them not missing possible coding. That would be a significant contribution to the fields. And you will see that not only for the reporting, they don't miss a reimbursement, but also significantly accelerate the data extraction for research purposes. Okay, so we also have another example of detecting the cancer recurrence. This is for the research purposes. So with a similar technology, not doing the ICD coding for the ministry reporting purposes, but it's actually identify very specific risk factors and interesting facts that to do research. So we collaborate with the Cancer Care Manitoba and looking at how we're going to develop this AI machine to extract, to identify if the nodes actually saying the patient have a recurrence, and that we can look at that if you extract the evidence, extract the important factors, and from the electronic patient records, and also generating the real world evidence. Okay, so that we built the model to detect the recurrence and its timing, and hopefully we can have higher compared to the existing model. There are existing models and the works has been done in this field, but we hope that our model can be with a higher sensitivity, specificity, and also higher positive predicting value. And we can identify the more accurately when the recurrence has been talked about, has been identified in when the patient comes. So why this timing is important is because they can actually accurately calculating when is a disease-free period of time. Okay. So the data sets they are collected and prepared for us is having this many patients. It's actually from 10 years ago, they gradually accumulated this data and trying to use these notes to prepare for this research. And there are hundreds plus thousand nodes, and only 4% of them actually been deemed it's a positive. It means that if you look at this, read these notes, and the clinician read it and actually consider that these notes, I read these notes, I will say, yes, I can say that there is a recurrence of that patient. Okay, so you can see that it's also extremely imbalanced data sets. And so they also prepared a validation data sets, which is another 3 years of data collection after the training data collection curation period of time. So those data sets was never really in the training section, and they included 15 patients, and looking at the of 15% of 16% recurrence. The nodes would have been also about the 78,000 nodes and 3.8 positive. So it's a similar cohort, similar patient actual behavior, and but with a different period of curation of the data sets as a validation. So we checked the contextual NLP model, and with a clinical, the BERT is a general, the BERT architecture, and the clinical BERT is actually trained on the PubMed, the literature, and the bioclinical is actually trained also on the mimic data sets. Okay, so then because we just used the traditional, right, the BERT model, the limitation is a 500 token. So the nodes which were actually longer than that will not be able to, we cannot take it. So we experimented if we take it from the head, from the beginning, from the end in between. So we actually did a bunch of experiment. The results are actually very interesting. So all of them, if you look at it, they reached a very high the AUC curve, so the accuracy as well. And you can see that without any pre-telling them what kind of words indicating the recurrence, etc. So then they actually reached a very high accuracy. And also interestingly, that you can see that when they trained in a certain way, and the clinical BioBERT or UML-BERT, which added another layer of actually use the clinical metathorosis, and they are not making a huge differences. So the generally trained bird, and it's already performed quite well in this task. But also very interestingly, with the same group of Cancer Manitoba group, they have their colorectal cancer data sets. I didn't present it here, but they have the similar sets, but it's looking at the colorectal cancer. And we use the same model to process the colorectal cancer sets without any prior kind of knowledge about identify how the colorectal cancer specialists and looking at dictate their recurrence language, then this model actually can perform very well as well. So that is that we're in the middle of reporting this research. So the significance here is that they eliminated the need for meticulously generate the site-specific terms in order for this model to perform better. So that is one of the advancements we find is very meaningful in the clinical. So another is that when you look at the higher domain, when the AI, often the AI related to the advanced clinics, we look at the pattern recognition to say why it's happening, and the forecast if the trend goes on, and what I will do in my operation or the patient actually will behave. And then we'll see that what will happen next is a predictive model. So that's probably quite a common AI tasks, and what can happen the best. Okay, so here I use AI in a very loose term of many times, and it actually should be saying as machine learning building that model in the data. So we actually looking at the kidney disease that we worked with the Alberta Health Sciences Services. We worked with doctors at Sunnybrook and the Grand River Hospital. And on this understanding, the chronic kidney disease, CKD, and it's one of the very prominent disease actually among the Canadians, and particularly this actually, the disease burden, in terms of disease burden, it is probably highest. The cost of treating a dialysis patient is actually higher than treating a cancer patient. Okay, so when your function gets degenerated, there are things you can do, put on your dialysis. So there's a peritoneal dialysis, which is you can stay at home, do it by yourself. Okay, there's a hemodialysis, a very complex machine, and you have to go to the hospital. Sometimes now they start, you can also stay at home, but circulating the blood obviously is much more invasive and expensive process. So that the PD, the peritoneal dialysis, is one of the cornerstones that really every programs and trying to promote and trying to have. However, they don't have the general standard, the standard of say what kind of patient would have been eligible for PD. And many times they've been put on the hemodialysis, but they can benefit. If we actually look carefully, they can benefit even for the 6 months of PD treatment at home. Their life quality and the cost of treatment, etc., will be so much better. So that's where we try to set out to look into, can we build a model to identify the patient which eligible PD? And can we actually understand what kind of patient is most suitable for PD? So we collect the data from the Alberta Health Services. The 8 hospitals collecting data using DMAR software, the electronic patient record systems for dialysis program, and meticulously collecting the data. There's a lot of patients. It's not just like I say, the 8 hospitals only have 600 patients. But when we actually processing the data with the complete data sets and take out the biases, etc., and we only left this 600 patients for that data sets. So any machine learning people will say, yes, this is too small, but lots of times in rare disease in medical terms that we do want to actually have that, yeah. So with that being very small data sets you have. So we actually identify the common patterns of what would be eligible, and we also identify the common patterns of what is not eligible. So, and then very interestingly, and this actually model can also identify what is actually out of the ordinary. So if you look at the first patient and the second patient, and they fell into the eligible patient, but then be named ineligible, but they be named eligible. And then the rest of the patient, they should be eligible, but they are not eligible. So that is where actually prompt to think if we can make this patient all eligible, that would be really, really good, right? So that is how we actually work with them. And also we understand what is the most important features that can make a person, particularly at the patient individual level, to say that in your case, what make you ineligible, if there's any modifiable factors that we can look at it, you can change. So all in all, my last words is what AI can do in healthcare. So improve many areas for optimizing the operation, to personalize the care, and to basically improve what have been done, what we have been doing right now, and also can allow us to predict what could not have been done in the past, but could have been done in the future. So the team was working in this number of projects as our gratification would have been in the collaboration with Cancer Care Manitoba and the hospitals, the doctors in the hospitals, and the Microsoft, the government fundings. So thank you very much.
Okay, thank you, Helen. We have time for one very quick question, so I'll ask it. So my brother-in-law does this coding for a living, and he's in the American system. And so a big part of what he does is look for codes that have much higher billable amounts. Is this a consideration for in your work as well? The cost of how much you can recover by coding?
I believe that this it's not in the system, in our algorithm to do that, but but the training, the data sets from Mimic, which is generated in the US, right? And that kind of bias, and it's probably already been embedded in the training data sets.
Right, right.
Yeah, so
Okay.
then those kind of higher billing codes will inevitably show up much more, or becomes more likely billing codes.
Okay, thank you again. Very
You're
good.
welcome. Yeah.